I'm one of the I'm one of the pediatric hematology oncology doctors here, and I specialize in transplantation and gene therapy. Let me go through some slides today. Oh no, let's see if it gets there. We go. So a lot of what we're going to talk about today involves kind of genetic changes. So I thought that the first thing I should really kind of show people is kind of when we're talking about genetic changes, what are we really talking about? So here is chromosome 11 is where the sickle cell gene, or the gene that gets changed to end up being sickle cell, is located. And the real change is from a certain type of amino acid called glutamine to valine. And what causes that is what causes the sickle cell, the cells to turn from kind of normal donut shapes into more of the sickle cell shapes. We're going to talk about how we can fix this. So sickle cell disease, as most of the people on this call, of course, are aware, is when the cells go from being normal donut shaped to being sickle shaped and end up causing obstruction and leading to pain crises and other issues. Those other issues can be quite varied, depending on the patient, depending on the age. Obviously, one of the things that we tend to see is the older a patient is, the more likely they have complications, the more likely they are to see the things that are on this list. The kind of the more complications you have usually are, the sicker you get, the more likely you are to qualify for curative efforts, whether or not it be transplant or gene therapy. But it seems unfortunate at times that you have to be sicker to be able to qualify for these kind of procedures. But unfortunately, given the fact that they're still experimental in nature, they still do require people to be sick enough that it's worth the risk. It's a risk-benefit analysis when we're really looking at things. So briefly, I wanted to talk about stem cell transplant, which is my first love. The main thing with stem cell transplant is that you're getting cells from somebody else. So whether that person is a donor that's somebody related to or not related to you, that donor can give bone marrow cells or something called peripheral blood stem cells, and then we would give you some chemotherapy or some type of therapy, and we would infuse these cells back into you via an IV, and we would start to produce that other person's stem cells that don't make sickle cell. And that process will allow you to make non-sickle cell and to reduce the amount of complications or even eliminate the complications you have after the transplant. Another option is cord blood transplant. That is when cells are collected from umbilical cord blood after a baby is born. Those cells are essentially squeezed out of the cord and frozen and kept. They're good for kind of patients that are on the smaller side. But what we've seen with sickle cell disease is they're kind of naive cells, and because of that, they unfortunately end up being kicked out of the bone marrow environment quicker than other stem cell types do, because they're naive and they take some time to set up. And a lot of patients with sickle cell disease have very, very robust immune systems, which can make it so that the cord blood just doesn't take well. So again, the point of the slide is to mean that allogeneic is from somebody else. The counterpoint to that is an autologous stem cell transplant only involves you. It's either we take your own bone marrow cells or we take your stem cells, we manipulate them, and they give them back to you. That's where gene therapy really starts to kind of come into the equation and kind of the conversation. Really, what is gene therapy? So gene therapy is taking cells from you, fixing them, and then reinfusing them into your body so that they can grow and develop in your body and fix the problem that's there. Gene therapy is used for a variety of different diseases across the world. Anything from severe confined immune deficiency, other kind of metabolic disorders, things like obviously sickle cell, thalassemia. There is probably more gene research going on involving gene therapy products now than there have ever been ever. So there is certainly a lot of patients that are getting gene therapy that's not just sickle cell related. Gene therapy for sickle cell disease, the reason that became kind of a thought is because we saw that single change, that glutamine to valine being a single gene change. How can we fix it and have that gene change go back to being normal or start to produce a normal healthy hemoglobin? There are several ways we can do that, and we'll talk about those. This is just a slide kind of showing that the beta globin, which produces normal hemoglobin, versus the it depends on whether it's sickle beta globin or whether it's normal beta globin, will determine whether or not you have sickle cells or not. So there are several options for gene therapy. One is to deliver a new healthy beta globin. So essentially, we engineer it using our own cells. We put it into what we call a lentiviral vector, which is essentially an outer shell of a virus. And the new type of functional gene goes into that inside that shell. It goes and affects these new other cells and then starts to be produced. This will essentially start to make it so that you're making a new type of beta globin that does not produce sickle cell disease. A second option is to do something very similar, but to give you the ability to make fetal hemoglobin or gamma globin. That's when you do that infusion, you would have the same thing go on. We would put it inside a lentiviral vector. It would infect the cells, and it would start to produce that type of hemoglobin. Both of those involve lentiviral vectors. Those are probably two of the most common types of gene therapy that are occurring right now, aside from gene editing, which we'll talk about in a couple minutes, or right now. So the third option, and a lot of people have kind of heard about this, is what we call CRISPR-Cas9, and that's really more of a gene editing technology. What really happens there is we use a certain type of process or certain type of procedure where you create kind of a template for this type of nuclease to go in, and it cuts out the part of the gene that you don't want, and it puts in a normal part of the gene that you do want. When we are first born, we switch from having fetal hemoglobin to making adult hemoglobin. For people that have sickle cell disease, that means they go from making fetal hemoglobin, which does not sickle, to sickle cell hemoglobin, which does sickle. What this would do is turn back on the production of fetal hemoglobin, and hopefully, if it turns on well enough, you're going to make enough fetal hemoglobin that you're not going to have the issues associated with sickle cell disease. One of the questions I often get from people is, do I need chemotherapy for gene therapy? And the answer is yes. The only way right now that we can get the new gene therapy product to take and be effective is to create a little bit of space in the bone marrow environment. There are two main types of chemotherapy that are being used. One is called busulfan, and one is called melphalan. They're I always kind of say that busulfan is kind of chemo, like really heavy duty chemo, where melphalan is a little bit more on the reduced intensity basis. They have very similar side effects, as you can see here, including needing transfusions immediately after getting them, nausea, some vomiting. Some have a little bit of increased risk of other things, which you can read here. We do, both of these chemotherapy regimens, or these drugs that we use, are used in stem cell transplant all the time, so we have a lot of experience with them. What is different here is that they're really just being used in isolation as a single agent, whereas in transplant and other things are usually used with other things at the time of transplant. One of the questions, the lentiviral vector question, comes up often when I'm meeting with patients, and it's particularly in relation to the HIV virus. It is the same type of vector where that HIV lived in. So it's essentially HIV's house without HIV in it. As I mentioned earlier, the new type of hemoglobin gets packaged inside this vesicle, and it infects the new cells, and the cells start to manipulate the DNA and start to grow from there. When we talk about gene addition, this is where beta globin kind of starts to be produced, especially the non-cyclin beta globin. The Bluebird Bio company has looked at doing this product, and what they do is select out a certain portion of your stem cells, which is shown here. That's called apheresis. The cells then get manipulated so that they are making the type of product you want, which is that new type of hemoglobin that doesn't sickle. And then they give you this chemotherapy conditioning to create that room. And then the cells are reinfused back into your body, and it's all done via IV. The cells then grow in your bone marrow environment, and over time you're followed closely to kind of see how well they grow. And during that time period is when it should be taking hold, and that this stem cell population should be increasing in number. Hemoglobin F gene addition works very similarly. In this case here, you're just watching to see the amount of fetal hemoglobin that gets produced. If you're, with fetal hemoglobin, you have, again, less sickle cell combination. When we're looking at any type of gene therapy product, there's expectation is that there's always going to be some sickle cells still around. It's not going to be a complete removal of the sickle cell population. There's always going to be some that's still there, but these new types of hemoglobin, whether it be fetal hemoglobin or whether it be traditional hemoglobin A, you will see a growth of those that will help outcompete the sickle cell. Essentially, kind of in essence, like what happens with sickle cell trait, where people have some sickle cell, but they don't have enough to cause problems. So real quick about gene editing. So again, what we talked about is that at birth, you switch from having from fetal hemoglobin, which is depicted here as this beta hemoglobin and the gamma hemoglobin. And then, alpha and the beta, alpha and the gamma hemoglobin, and then you swap off and you end up making alpha and beta. And what happens here though is that the process of birth is where that switch turns. That's because of this BCL11A gene. And again, this is the one that if we can change this and turn this back on, then we can start to make fetal hemoglobin again. It gets shut off. So what you do is you go in and you cut the thing that causes it to shut off so that then it starts to be produced again. And this is using that CRISPR-Cas9 process. So again, just kind of showing it more of a pictorial view. There's a guide molecule that shows the right place to cut so it doesn't cut where it shouldn't be. And then the healthy new strand of DNA is produced. There are two main approaches that are being used right now. One is to correct that area of the genome that is affected directly and just cut out that beta globin and cut out the part that makes the sickle cell and put in something that makes normal healthy beta globin, or to turn off that BCL11A and essentially make more fetal hemoglobin. So really to make normal beta globin or to make normal fetal hemoglobin. So as you can see here, CRISPR and gene therapy have something in common. They both are looking at whether or not we want to turn back on regular hemoglobin production either via addition or by editing. And they're both looking at potentially whether or not you can go after beta globin or you could go after fetal hemoglobin. CRISPR-Cas9 functions can replace hemoglobin, beta hemoglobin that makes sickle hemoglobin, or can remove the gene that stops making fetal hemoglobin and leads to production of fetal hemoglobin. So what is the gene therapy process? So say you are interested in gene therapy, what does it entail? So first thing would be meeting with a stem cell transplant or gene therapy doctor to talk about what clinical trials are available in the area. Gene therapy is only available in a clinical trial right now just because it's still an experimental phase. Most clinical trials are somewhere between phase 2 and phase 3 right now, which means they're still kind of in that developmental phase. When you get to a phase 3 study, that's when it's really starting to be broadly kind of experimented on, or experimented, I guess, wrong choice of words, but broadly kind of expanded to a larger patient population because it's already undergone safety and efficacy evaluations. You would consent to the clinical trial. Then there's what we call a workup, which really is looking at your whole body making sure you don't have any signs of infection or any reasons that you wouldn't be a good candidate for this product. So if your liver's not working well, you may not be a good candidate. If for some reason your other organs are not working well for whatever reason, you may not be a good candidate either. That doesn't mean you may not be a good candidate forever. It often means that that's a bad time for that, and you can repeat it and do it later, or get reevaluated later. Once we find out that you're a good candidate, then we would start exchange transfusions. Really, the point of that is to make your bone marrow environment as healthy and as happy as possible. So you would get these exchange transfusions monthly for several months until we can get your sickle hemoglobin consistently below 30% for several months. Then we would collect your stem cells. To collect your stem cells, we do have to place a temporary line often in your neck so we can collect that on that apheresis machine. It can take multiple days to do this, just because collecting stem cells from a patient with sickle cell disease is tricky, and often is a process that does take a little bit of finesse. So often patients are really being collected for 4 to 5 days. And even rarely patients would need to come up, get collected 2 rounds of collections to collect enough cells. They collect enough cells so that they know that when they actually start to process this gene therapy product, they're going to have enough to give back to you so that it can be effective. Once the stem cells are processed and the gene therapy is ready to go, you receive the chemotherapy, and then the cells are reinfused. Patients are then admitted into the hospital and kind of await recovery after the cells are infused. That kind of recovery period of an admission period usually is about 4 to 6 weeks for people to get out of the hospital. It's a little shorter time than the transplant itself is in general, and which is often a benefit. The main differences between stem cell transplant and gene therapy are that stem cell transplant, the cells are somebody else's cells. Gene therapy, they're your own, which is a big benefit. There's no risk of graft versus host disease with gene therapy. It is the one thing the one tricky part about gene therapy is we do not know if it's going to be a long-term cure. It may be more of a therapy and less of a cure. With transplant, has had a long track record. I mean, for sickle cell disease, we've been doing it for 50 years. No, it's been on 40 years. So there's a lot more track record behind that. We know that people can have long-term cures from it. Whereas gene therapy, we're still kind of in the early phases. I think the longest patient out from gene therapy is somewhere around 10 years at this point, maybe a little bit longer than that. And so that's still kind of in the early phases. There's a little bit more risk of kind of organ damage and infection risk with stem cell transplant because you're going to need to be on immune suppression after because it's somebody else's cells, and you need to get heavier chemotherapy than you're going to need with gene therapy. And like I mentioned earlier, you're in the hospital for usually at least a few more weeks, at the very least, for stem cell transplant versus gene therapy. So what's available locally? We are opening CRISPR-based options here at Atrium Health in the next couple of months. Ages 12 to 30, based on which study. There's 2 studies we're looking at. The Bluebird Bio product is a hemoglobin A product that is between ages 2 and 50, and that one is not open here at Atrium, but is open at several places in North Carolina as well as in Alabama. So anybody looking for resources or questions, there's some great sites. The CRISPR site is a good one. The Bluebird Bio site is a very good one. There's a lot of other kind of more generic sites. Be the Match, sickleoptions.org is excellent, and curesickle.org is also an excellent site, and can be really good resources for patients. I heard a question. So if you want any more info, we're certainly happy to talk with you and talk about your options. I am a pediatrician, so I unfortunately am limited a little bit in terms of how old a patient I am able to see. Typically, I can see patients up to about 30 years of age. So if you're over 30, I would have to refer you out to an adult center. The one that I typically refer people to is to Atlanta, because they have a kind of a robust kind of adult transplant / gene therapy program there. my contact information as well as our coordinator's contact information is listed there. And then if you're interested in contacting somebody on the adult transplant side, their number is listed there. I will tell you that we currently do not have somebody that does transplant for adults at Atrium Health yet. The closest we come is me, which we do up to age 30. Questions?
That was some good information.